topic is obstructed labor basically. Obstructed labor with a good maternity care, nice antenatal clinics, regular checkups of the patients, right time diagnosis, all the investigations being done in the right time, and respectful maternity care being given all throughout and during delivery, pregnancy, all, the chances of obstructed labor is gradually very less and less. But still, it's an important topic. So we are discussing here the obstructed labor. These are the learning objectives which we are going to talk about today on the obstructed labor. The number one is the discussing symptoms and signs, management of the prolonged and obstructed labor. Then another is to state the definition of prolonged and obstructed labor in relation to expected duration of normal labor. And the third most important is the learning objective is how to interpret partograph finding to diagnose prolonged labor and obstructed labor. So these are the things which we are going to have in this presentation about the obstructed labor. Now, the obstructed labor is one of the most common cause of maternal mortality, and mortality and morbidity from the prolonged and obstructed labor can be reduced. Number one, by appropriate obstetric examination during labor to rule out the cephalopelvic disproportion and malpresentations. Number two, by proper monitoring of the progress of the labor through partograph will also reduce the chances of obstructed labor. And third is timely decision making and what are the interventions can be done is done. Then the other causes for the maternal mortalities, hemorrhage, sepsis are important, but the obstructed labor is also one of the very important topics. Now, before talking about all about the obstructed labor, we should know the few definitions about prolonged labor as well as obstructed labor. What is prolonged labor? After the onset of regular rhythmic painful contraction accompanied by cervical dilatation, that's a true labor when the labor is longer than 24 hours. That is a prolonged labor. And obstructed labor is mean in spite of strong uterine contractions, fetus cannot descend because of the mechanical factors and due to the fetal and maternal reasons at the inlet within the cavity or the outlet. So that is obstructed labor. Now the obstructed labor does not end at delivery, and strengthening postpartum care is also our responsibility. And one small step in technology and one giant leap for the mothers is right time diagnosis of obstructed labor can do, and we can save the mothers by saving the mothers, giving them a life. Now, what actually will happen, the mortality and morbidity, or because of the spectrum of the impact because of the obstructed labor, there can be a mortality and morbidity. There are chances the patient will end up into the sepsis, osteomyelitis. There can be a diastasis pubis, foot drop, chronic pain, infertility. There can be a vaginal scarring, depression, anxiety, maternal death, stillborn infant. Then there can be a neurological damage, cerebral palsy, paralysis, mental delays. Then incontinence of the urine, incontinence of the feces, and a formation of the fistula. These are the most of the important maternal and mortality spectrum of the impact because of the obstructed labor. So it's not easy to deal with all of them, and they're really serious and severe for the future. Now, these are the factors which influences the delivery and the processes we call this PPP. P is a power, other P is a passage, and third P is a passenger. When the weak uterine contractions lead to unsatisfactory progress of the labor, or it will represent to the prolonged labor. Now that's a pelvic. This is a passage. This is a pelvic adequacy. So inadequate pelvis in relation to the parts leads to CPD, and it can cause the obstructed labor. And the passenger means fetus. If the positions of the fetus or the conditions and the presentations are so important, malpresentation, malposition, any congenital anomaly can lead to prolonged labor, and ultimately it can lead into the obstructed labor. Now the malpresentations and malpositions there is a difference. Malpositions is the abnormal position of the vertex of the fetal head, and while malpresentation when the fetus with a different other presentation part other than the vertex. So malposition is correlated with the vertex and malpresentation is other than the vertex. Now, why we are worried and why we are worrisome? Because there can be a maternal complications and a fetal complications. Maternal complications, a mother can die. There can be a rupture of the uterus. Then can be a formation of the fistulas because of the long-standing head impacted into the cavity, leading to rectovaginal fistula, can lead to urethropistula, can lead to this fistula into the bladder. That's a VVF can happen. And then premature rupture of the membranes, slow dilation of the edema of the cervix. Maternal fatigue is also worrisome, and sepsis. Fetal complication, the worst one is the fetal death, birth asphyxia and its complication leading to all CP and everything. Then caput can form and excessive molding of the head and a skull, and ultimately the complication of the fetal sepsis is also there. This is one of the diagrams because of the pressure necrosis on the fetal head leading to so much big head and all the caput formation, and this is also a worrisome part. All the vesicovaginal fistulas because of the compression at the part, and they can lead to the fistula because of the partial necrosis, ischemia of that part, and can lead to vesicovaginal fistula. And another clinical situation to understand the prolonged labor are again, because the prolonged obstetric labor, we need to be worried about the incontinence, the maternal things, all the treatment, prevention, precognition, and the bladder care is important. And because of the passage, these things can happen. Now, what are the standards for the emergency obstetric care? It is feasible to develop the standards of emergency obstetric care in a low-income countries and using the multidisciplinary team that involves the health professionals in all grades. Another important point is the involvement of the health professionals might propose a successful implementation of the ownership on the sustainability. Because of the 2030 sustainable goals, they also suggest us to talk about this. The involvement of the hospital managers, the policy makers, the early stage criteria based audit, everything is so important, and how to regards all this. So standards of the emergency care depends upon all the factors, right? From the professionals, the managers, the support team, the equipments, the all, everything are very, very important. Then there is the clinical situation to understand what is the prolonged labor and what is the obstructed labor. Women has been experiencing labor pains for 24 hours with or without delivery. Then the prolonged latent phase, that's a true, but a cervical dilatation is not progressed to at all and has not reached 4 centimeters in 8 hours. Then prolonged active phase, when the active phase is more than 4 centimeter dilatation, but new WHO guidelines say the 5 centimeter dilatation of the cervix is not occurring at the rate of 1 centimeter per hour, and that is also a prolonged active phase. And the prolonged expulsive for when the female, the patient, the woman is into the second stage of the labor, dilatation is 10 centimeter, but the baby is not delivered for more than 2 hours, then the woman is urged to push. She is pushing, but she is not able. So this is the 3 difference: prolonged latent phase, prolonged active phase, and prolonged expulsive phase. So this is another important point when we talk about the obstructed labor. Now, clinical situation to understand prolonged and obstructed labor. Obstructed labor is a clinical diagnosis that can occur at any time during the active phase of the labor or the second stage of the labor. And these needs to uterine activity is good, but the skill is no descent of the fetus. It can occur due to the CPD, malpresentation, malposition, or any fetal abnormalities are there. It can be prevented by right obstetric examination, monitoring, and the process of the labor. So one is the obstructed labor, and another is an inadequate uterine activity, means less than 3 contractions in 10 minutes, each lasting less than, it should be more than 45 seconds, 40 seconds, and can occur during active phase of labor and can cause to the prolonged. So the inadequate uterine activity is another important point. Now, these are the simple some case scenarios. 26-year female, third gravida, admitted at 5 a.m., 11 June, with a complaint of labor pains, 2 a.m. Her membranes has ruptured at 4 a.m. She has 2 children and ages 5 and 2. On admission, cervix was 2 centimeter dilated and plotted the following findings on the partogram. At 9 a.m., the cervix dilated 5 centimeter. She has 2 contractions in 10 minutes, each lasting less than 20 seconds. Fetal heart rate 120, membranes have ruptured, amniotic fluid is clear. Blood pressure normal, 120/70, temperature normal, and pulse is 80 per minute. At 9:30 am, the fetal heart rate 120, and then the contraction is 2 into 10, each lasting less than 20 seconds, pulsed 80 minutes, amniotic fluid clear. You can see at 10 am, suddenly the fetal heart rate is 136, but the contractions, pulse, and amniotic fluid remaining the same. At 10:30, fetal heart rate goes up to 140, and the remaining all those things same. This is the part study of the patient there is no change till 12 or noon, because it's continuously same from 9:30 to 12 am. There is again contractions are not increasing, and the frequency and this thing is not increasing. So at 1 p.m. cervical dilatation 6, amniotic fluid clear, and BP is 110/70. So this is because it's almost 24 hours. It is called prolonged labor. Then what the management of the prolonged latent phase? She is in a true labor. Initiate supportive care such as ambulation, maintaining hydration, emotional support, and by birth companions are important. If women does not achieve 4 centimeter dilatation within 8 hours after the active above mentioned measures, now 2 things are very, very important. Obstetricians and the trained doctor, if available, should access the labor and decide the course of action, and refer the case to the higher center where it's not possible for where the facility of cesarean section and this obstetrician and the trained doctor is not able, then this has to be done. I'm talking about all these practices not in a tertiary care, but in a primary care also. How, when to refer the patient of obstructed labor is also important, and how to diagnose the prolonged labor is also important. Now, if there is a management of prolonged active phase, once the woman achieved the dilatation is more than 4 centimeter, start feeling partograph and monitor the progress of the labor. If cervical dilatation crosses the line and fetus and show that the fetal distress, do the following. Number 1, trained obstetricians should see the patient and available to access the progress of the labor and decide the course of action. And then again the same thing, refer the patient to the higher center where the facilities for cesarean section and all are available. Then it's a third part. It's a progression of the expulsive phase. Once the woman has achieved the full dilatation of the cervix, monitor fetal heart rate, contraction, descent. In delivery of the baby does not happen within the 2 hours of the full dilatation, and the signs of fetal distress are there. Again, 2 things are very, very important. It should be seen by a trained obstetrician and decision the course of action, and same it should be referred to the higher centers where the cesarean section can be done. Now, this was the case of prolonged labor, but now we are talking about the obstructed labor. She 28 females, second gravida, admitted with a complaint of labor pains, membranes ruptured at 4 am, 2 children, 5 and 2, cervix is 2 centimeter dilated. And the partograph, at 9 am, cervix was dilated 5 centimeter, 3 contraction in 10 minutes, lasting for 20 to 40 seconds, fetal heart normal, membrane rupture, amniotic fluid clear, BP normal, temperature normal, and pulse is 80 per minute. The same case was observed with the same things from 9 am till 1 p.m. Almost everything is same. The contractions even not increases by 12 am, by the 4 by 10, and the fetal heart rate is coming 40 to 100, and amniotic fluid and a meconium stain, and cervical dilatation is 6 centimeter at 1 p.m. Then this can be obstructed labor, and obstructed labor is a clinical picture, history, age, parity, all are important. Previous operative delivery, previous stillbirth, what is the duration of the labor previously, and previous history of the babies with the developmental anomalies, what was the progress of the labor, and when the ruptured membranes, and what are the timings are very, very important. On the clinical findings of the general examination, physical, mental exhaustion, dehydration, ketoacidosis is very important, and the fever, shock due to the ruptured uterus or sepsis, and the fetal conditions, try and listen the fetal heart, vaginal examination, foul smelling, meconium may be seen, amniotic fluid may have already drained away, edema on the vulva, vagina hot and dry, and the large caput is another important point. The findings on the clinical examination, abdominal examination, fetal head above the pelvic brim. Women have the frequent and strong contractions. They have stopped due to the uterine inertia or sometimes uterine rupture, and the Bandel's ring sometimes may be seen. Areas between the upper and the lower abdomen when it becomes visible, and depression across the abdomen at the level of umbilicus, and shape of the uterus look like a peanut shell. So it's a really very, very worrisome, and we have to take real start management over there. In the ideal situation, complications of the obstetric labor can be avoided with a timely identification of the cervicopelvic disproportion, appropriate management of the progress of the labor. If obstructed labor has been confirmed, do the following. Then rehydrate the patient, start IV lines, ringer lactate, and it should be at the rate of 25 to 30 drops per minute. Give antibiotics, ampicillin, gentamicin, metronidazole if needed, and refer to the patients to the FRU. FRU is very important because we have to refer the patient. Now, the signs and signs of ruptured uterus, we should keep in mind when there is obstructed labor. If there is a ruptured uterus, shock may be there, severe abdominal pain, vaginal bleeding may present. Signs: abdominal tenderness, fetal parts felt superficially, uterine contour is not felt, and fetal heart sound not heard. It's a life-threatening condition. Manage shock immediately and refer the patient immediately. The global burden of the disease because of the obstructed labor is an important cause, and the maternal and fetal mortality. So better understanding of the pathophysiology of myometrial contractility is very, very important. And the moment we should have a simple clinical facility, identify the dystocia and treat it appropriately. Ultimately, the incident of obstetric labor will be minimized by ensuring the adequate nutrition of the girls and young women at the right time is another important point. These are the another global burden remains important cause throughout the world, and we should know about it. Then, because of the it's a global burden, one of the important cause of maternal deaths. Parthographs help to identify it. It's any deviation from normal in fetal and maternal condition and progress of labor early. Prolonged and obstructed labor should be diagnosed early, managed properly, and prevent complications. The adverse maternal fetal outcomes. The obstructed labor has a different maternal outcomes such as rupture, postpartum hemorrhage, puerperal sepsis, vesico-vaginal fistulas, rectovaginal fistula, and all of them can lead to death. Besides fetal outcome, including birth asphyxia, stillbirth, neonatal jaundice, umbilical sepsis can occur to the patients. Then we are very much important point. The skills of the specific preventing and managing prolonged obstructed labors include identification of the risk factors, assessing the pelvic outlet, diagnosing the presentation and the position of the baby, assessing the descent of the fetal head, and recognition of the obstructed labor. Augmentation should only be done in indicated cases and at equipped centers under the expert medical guidance. Thank you so much for patient listening.